evening, everyone, and welcome to our latest webinar on surgery and the recovery process with Mr. Neil Barber and his lovely CNS nurse, Jo Oakley. We felt it was a really important week, as obviously it's Kidney Cancer Awareness Week, to do a webinar on the importance of awareness, and then obviously to talk about surgery and recovery from surgery. So this is very much your session today, so please ask as many questions as you would like going throughout. Neil and Jo are very kindly going to talk a bit about their job roles and the importance of also your recovery from surgery and anything you would like to ask. So I would like to now, if possible, hand over to Neil, if that's all right. Start the session, please.
Thank you very much, Lucy. And it's a pleasure to be here and to be sharing a screen with Jo. Lovely Jo. I'm not lovely, apparently. I can take that. That's one for the team. So, yes, my name's Neil Barber. I'm a consultant neurologist at Frimley Park Hospital, which is in fact part of a bigger trust now known as Frimley Health NHS Trust, which is based just outside the M25 near Camberley and covers down to Farnham and up to, as a trust, up to Slough and north of that. It's about a population of 1 million or so. And a number of years ago, we became the regional kidney cancer centre for a cancer network, which is what that pretty much outside of the M25, including Guildford, Red Hill, Dorking, down to Worthing and Chichester, out to Basingstoke, and again up to Wexham and Slough. And that covers a population of about 2.2 million. As I was appointed as a consultant now 17 years ago, God help me. And as over the years, as we then gained this position as a regional centre, our team has grown to involve Jo. I don't know how many years ago now, very many years ago. Seven years ago. And also 2 other full-time consultant surgeons who deliver with me this regional specialist renal cancer service. And we also have 2 other visiting surgeons. So it's a team of 5 surgeons. And over the last few years, the volume of as a regional centre just continues to grow, and we're now delivering well in excess of 300 cases a year. Maybe because of our demographics and the arrival of the Da Vinci robot to our unit, which was in 2010, the majority of our work has really become robotically assisted surgery. So that's keyhole surgery using a very expensive sewing machine, basically. And that's allowed us to do more and more complex operations, and particularly operations that involve just removal of the kidney tumour and then reconstruction of the kidney, which is we call a partial nephrectomy, maybe wrongly, but it's removing the tumour and putting the kidney back together again. So that has become really the brunt of our service, and we in fact do more of those procedures, I'm told, I don't know for sure, than any other unit in the country, and that's just short of 200 a year of those kind of cases. So this is, we've seen a huge change in the shape of our surgical delivery in the treatment of kidney cancer. And as many will know, if you have kidney cancer, really the first port of call in terms of intervention to try and cure you is surgery, and that's either removal of the kidney or with the tumour, or removal of the tumour alone. So that is always the mainstay of treatment in an attempt to cure people of kidney cancer. In terms of the process of the surgery, as I say, most of it is done with keyhole. We hardly do any open surgery now. And most people are out of hospital in a very short time. In fact, for the partial nephrectomy, the most complex operations, the average length of stay is 1 night. And then I guess I will hand over to Jo, because Jo probably knows more about what happens to people after they leave hospital and how quickly they recover, but also what the kind of experiences of people that come through to us are often traveling quite a long distance. And Jo really is the fulcrum of the service, along with our fellow, in terms of what we hope is delivering a high quality service, in terms of a sort of constant point of contact. The phrase used is key worker, but it's much more than that in terms of the support that's provided for our patients, both in the run-up, during the operation, and indeed afterwards, in terms of recovery and planning thereafter, in terms of follow-up and if any further treatments required, or just in terms of surveillance. So I'll hand over to Jo to talk about her job.
Lovely, thank you for having me. Evening everyone, my name's Jo Oakley. Like Neil said, I'm the kidney cancer specialist nurse at the Frimley Renal Cancer Centre. I've been in post now for almost 7 years, worked at Frimley for over 20, I have to say, and actually been a qualified nurse for over 32. My background is urology. I've always loved urology, and the opportunity came up to work with Neil about 7 years ago, and I jumped at the chance and I haven't looked back since. So my job is basically to support the patients from the beginning of their cancer journey, so to speak, through their diagnosis, through their treatment, through their recovery. So I see the patients with the team initially at point of diagnosis in clinic, where they're given my contact number, and then they have access to me pretty much all of the time thereafter, right the way up until I see them in clinic with their histology results, and then obviously see them for their follow-up appointment, which can be anything up to 9 to 15 years post their original surgery. So I have a lot of contact with the patients, and I think this is really beneficial for patients to be able to have somebody that they can just pick up the phone and contact and can ask those questions that they may not feel confident enough to ask the consultants, who they feel are very busy people, that they can't possibly ask those questions because they're silly questions. But as I say to all of them, there are no silly questions. It's a difficult time. It's a worrying time for patients when they're diagnosed with kidney cancer. We talked about surgery, and I'm not sure at this point whether or not people just want to ask some questions about recovery, but like Mr. Barber said, or Neil said, most of our patients who have a partial nephrectomy go home on day 1 and day 2. And that's where the hard work starts for them, because that's where their recovery starts. Day 1, they feel pretty good. They tend not to feel as good day 2 and 3 when they're at home. But we do tell them that, it may get a little bit worse before they start getting better. But by the time I speak to people 3 weeks later with their results, you'd be amazed at how sort of back to normal they are. So I'm not sure whether or not we want to just put some questions out there, or if there's anything else we want to know before we talk about a bit more about recovery. Can't hear you, Lucy. You're on mute.
Doing that. Thank you, Jo. You can also pop any of your questions in the Q&A box, and I can read them out. If you'd rather that, by all means, put your hand up. Carol, I can see your hands up. I'm just going to, do you want to show yourself, Carol? Unmute yourself if you'd like to ask a question. Or not? Okay, maybe that's an accident. Okay, I'll start with some of the questions I've got then, shall I, if anybody else would like to go first? No? Okay, so the first question I got asked is, what will my scars look like? How big would they be, Neil?
It depends, obviously, what surgery you're having. So as I say, there's, broadly speaking, you've got keyhole surgery and you've got open surgery. Open surgery tends to be reserved for, more advanced situations, be it the size of the tumor or the disease itself being more locally advanced and more complex, making keyhole surgery either, very difficult to the point that you shouldn't really be doing it, or more risky, essentially. But as I say, in the modern era, less and less open surgery is done. It's more and more keyhole type surgery, and that's what really influences the scars. So if you have a open surgery, then it can be a very big wound indeed. A sharp bite pretty much does it justice in terms of the size of it. It's painful. And that means a bit longer in hospital in terms of pain relief, but also more than that, as Joe was mentioning about when you go home. So it takes longer for any post-operative pain to settle itself down, and that means the recovery itself is slower in terms of getting back to normal activity. If you have keyhole surgery and the whole kidney's removed, then it isn't just one hole. In fact, most people use 3 or 4 holes, and one of those holes will be made bigger to pull the specimen out. So that's the whole kidney and all the tissue around it. And so you have, one larger, but much like an old-fashioned appendix scar, normally that kind of size, or a Phalansteal wound, like for a cesarean, something like that. Some people do. You're trying to keep the wounds as low as you can away from the rib cage, because the lower you can get, the less painful they are, because you've got less movement with breathing, basically. If you have a partial nephrectomy and it's a robotic, then it depends on the size of the specimen. So that, the tumor could be very small indeed, 1, 2, 3 centimeters, in which case the size of the wound is dictated by that. So your wounds can be much smaller. Most robotic partial nephrectomy procedures involve 4 wounds, depending what approach you do. We do a very unique approach at Frimley, but it's normally 4 wounds, and you're talking about 1 or 2 centimeters in size. And normally it's all these wounds are stitched up with dissolvable stitches and really heal up to the point within a year or so. Your people have to look quite hard to find them, in fact.
Usually after about 3 weeks, any scabs that have been formed have all dropped off. All the dissolvable glue has disappeared. We encourage patients to have showers as opposed to baths. It is quite funny the amount of patients that do speak to me and say, did I have keyhole procedure? Because they are expecting the wounds to be quite small, and they do forget about the fact that sometimes, like Mr. Barber said, you have to open, make it bigger to get the specimen out. So some of them are a little bit disappointed that they're not as small as we said they would be. But most patients are left with hardly any scar at all.
Brilliant. Thank you both. The questions are coming through now, as you can probably imagine. The first question is it typical to remove the adrenal gland in a radical nephrectomy?
So that used, I guess that's my one.
Please.
So if you historically, then a radical nephrectomy by definition included the kidney, the fat around the kidney. So that's one of the things that's different between us as human beings and other mammals, that we have this fat around the kidney, and that tends to be more in men than women because of the fat distribution, and the adrenal gland. So that was the traditional radical, that's what it meant. As time has gone on and understanding about the disease and the surgery in terms of achieving cure, we know now that you don't have to take the adrenal gland every time. And if you look in guidelines, the indication for including the adrenal gland as if the tumor is at the top of the kidney, so very close to the adrenal, or you're even worried that it might be involved in the disease itself. So it's more specific situations now where you may take the adrenal gland. Saying that, sometimes when you're doing the operation, it just feels safer in terms of a good, safe clearance to take the adrenal gland with it. A bit like the kidney, you have two of them. So as long as your other one is normal, and you will know that from the CT scans on the whole, then to take it is fine. And some people still do it routinely because they believe that the old, that original approach it remains right. But if you look at the guidelines, generally it's only removed on block, i.e. within the specimen, in very specific scenarios.
Thank you, Neil. I was going to keep firing these questions if that's right. Next question is, hi, I had a partial robotic removal of my kidney in September and I'm still feeling very tired. Is this normal?
Yeah, I can answer that one.
Thank you, Jo.
It can be. I'm not sure of the age of the person that's asking the question, but that sometimes has relevance. Obviously, the more mature that you are, the longer it takes to recover. And your body has had a thing. It's had a major operation, even though it's keyhole. To look at people, it doesn't look like anything's been done, but actually you've had quite a major operation. So the body can take a while to recover. So yes, it can be usually, like I said, depending on the age, to still feel tired. Saying that, it's worth maybe getting some your GP just to check some bloods. It may be completely not related.
Thank you, Jo. Lynette, did you have something you wanted to say, please? I can see your hands up.
Oh, hello. My name's Lynette Williams. I've had a radical nephrectomy 7 days ago as a result of an incidental diagnosis, actually, with no kidney symptoms just before Christmas. So the radical nephrectomy was because the tumour was 9 centimetres and it was done through open surgery. And I was home after 4 days as part of the COVID rapid response recovery plan at home. It's more about what your expectations are for recovery. I do have a key worker who was very engaged with me before the surgery, but I've not had anything since the surgery. So I'm just muddling along, trying to do the right thing and making sure I'm doing the right thing, to be honest. So it's so my scar is I would say about 12 inches long, and the only information I had from the surgeon was that it went as he thought it would, but the tumour was jammed underneath my liver. But I got to wait 6 weeks for my results.
Jo?
Yeah, I mean, expectations. You can go home, and we advise people to be as normal as they can be. So there's no restrictions on not being able to go out, not being able to eat what you want. You can eat and drink as you like, as you feel able. You are going to have pain. You've got quite a big wound there. So we just keep taking your painkillers as you need them, and you'll feel fatigued. So it's okay to have a rest, in the afternoon, but try and be as upright and mobile as possible. We encourage patients not to go home and lay in bed. We advise them to go home and try and be as normal as possible. But yes, you're going to be tired, so a little afternoon nap is absolutely fine. Your mobility, you can get up and go out as you feel as you want to. People say to me, how far can I walk? And I say, as far as you want to, but if you overdo it, your body will tell you. And most patients say that that's exactly true. The next day, they're completely wiped out, they're washed out. But I think that it sounds as though, just, take your painkillers, eat healthily, rest, and hopefully you'll be back to normal, or hopefully feeling better in a few weeks' time. Where did you have your surgery, Lynette? You've got a Welsh accent, I've picked up there.
So it was in the Royal Gwent Hospital in Newport, South Wales.
Yeah, I know it well. I trained in Swansea, so
right. So with the surgeon, Mr. Jim Wilson, and yes, I'm trying. Thank you, Joe. I am trying to follow that line. I have experienced and still can experience muscle twitching, which is sort of 24/7, which is getting in the way of my recovery. Really, I'm having difficulty doing that sort of rest and recuperation. My pain relief is paracetamol, but unfortunately at the moment I still need temazepam to sleep at night, which I don't want to take, and all the doctors and nurses tell me that the muscle twitching may go or it may not. So but I'm like you say, I'm listening to my body at the moment, and my family, who none of us are experiencing any of this, but we are. No. We're doing our best, yeah.
But your key worker, she still should be accessible. So if you have any queries or problems, I'm sure that, you could give her a call and she still would be able to help and advise.
I'll do that, Joe. Thank you very much.
Thank you. Another question that I've got, and I'm going to scroll up to, because so many that have come through now. I'm 2 years post laparoscopic radical nephrectomy. I then had an op 9 months later to fix a hernia using the same 15 centimetre wound from my nephrectomy. I now have a very obvious purple scar. Is it likely that this will go down, or am I stuck with it? Please.
Whenever you go through a wound twice, whenever you do surgery, you're damaging stuff, and you're damaging the skin and you're damaging the muscle, and it's never the same again. So when you go in there again, you've got like a double scar basically. So it will be, I have little doubt, it will over time shrink down, and as we know, all scars turn white in the end, and they shrink and they can pucker a bit as a result. But it will be, I have no doubt, quite a wound, I'm afraid to say. And you can have some of the issues that relate to that, numbness around it, as I say, puckering. Quite commonly, even though it sounds like you had a hernia repair, the repairs for when you get muscle bulging there, because it's not a hernia usually in the truest sense of the word, it's muscle weakness, because you're cutting muscle to get through to the kidney. It's just it's a side effect of where they live, is that you have to do that. And you may well, when you look down, see a bulge, or at least that it's not symmetrical. It's funny that obviously the patients see it more than other people do sometimes, and they're more aware of it. But it is one of the realities of open surgery, and what was the big revolution about, moving to the whole thing being dominated by keyhole surgery, as I say, keeping these wounds low. It's because we know not only are these wounds painful, not only does it take, as we heard, sometime weeks and many months sometimes to really recover from them, but there is also, issues relating to the wound itself, whether it's bulging, hernias, or just the sheer width and size of them.
Thank you, Neil. Next question. Can a person contract another cancer along with or after kidney cancer, please? To either of you, I suppose. Question.
Sorry, I missed the question.
Can a person contract another cancer along with or after kidney cancer?
Sadly, yes, they can. yes, sadly they can. And, you know, we have some patients of ours that have unfortunately been diagnosed with other cancers. And particularly because post-surgery, we are scanning people. Patients go into a surveillance program where they're getting scans maybe 6 monthly, yearly. So, you know, a lot of other things sadly are picked up through those scans. And I think, like Lynette was saying, her cancer was picked up purely by chance, and that's probably about 80% of kidney cancers are picked up purely by chance with patients having no symptoms. So the fact that we are scanning patients post their nephrectomy does mean that unfortunately some patients do go on to have other cancers diagnosed.
Thank you, Jo. The next question, please. Can you advise on how long the tingling and nerve-related sensations last, please, for after a partial nephrectomy? Also with the muscle spasms and the side muscles. Thank you.
I think I saw that pop up in the chat, and that was an open partial nephrectomy, I think it said in the thing. And and obviously that, again, that's not a dissimilar to wound to doing a radical nephrectomy, and will take time. And in fact, wounds really take up to a year to mature, and it's different for everybody in terms of the pattern of numbness followed by tingling and even sort of pins and needles, even sharp pains as the nerves recover in the skin particularly, and the muscles heal, and it takes time. It does take time. And we're in an era where we all want it to happen tomorrow, but nothing really changes, I'm afraid, in terms of the body healing. And of course we rely upon that. That's the miracle in many ways, that everything does heal up. But it does take time, and the bigger the wound, the longer it may take. Not in everybody, and for some people certainly that journey can be longer than others.
Thank you, Neil. Are you okay with me to continue with questions, guys? You've been wonderful so far, so thank you. I had a laparoscopic nephrectomy 2 years ago. Is it usual for the lower tummy to still be a little bit swollen and uncomfortable after exercise?
Do you want to take this one, Mr. Barber?
Okay. It's unusual. It's a sort of, it is not a surprise to hear that, I suppose, to put it another way, because again, it depends slightly where the wound was made to extract the kidney, the specimen, if you like. And again, it's a muscle cutting incision. And I was talking a little bit about seeing a bulge related to that, because you're healing with muscle, not firmer tissue. And it will always, there's a chance in some people that will remain relatively weak. So the tone of your abdominal wall is different at that place. So you get this bulging. And if it's a bit weak there and you do exercise, and obviously you're putting different kinds of strains onto it than was designed. It's not how you were made in the first place. So sometimes there can be a true hernia there, and if it's very symptomatic, then like the previous person, you can be looking at surgery to try and often what it is putting mesh in there to give strength and robustness to the abdominal wall. But the abdominal wall, unlike muscles in the limbs, it's fixed really around the spine and the ribs, and otherwise it's free floating round to a fibrous joint in the front. So a lot about our shape of our abdomen is about the tone of that muscle, and it's that tone just in the area where it's been cut and the nerves that run through there that can change after surgery. So yes, it is normal, inverted commas. Is it perfect? No, it's not. And there can be instances where there can be further intervention to try and help. But it isn't. It is an intervention where you have to be aware that it may not help, and you can end up with bigger wounds, as we heard earlier on. So it's not without its potential risks as well. So it is, yes, it is common, but if it's really impacting on quality of life, then it's worth exploring whether some intervention may be appropriate, and you may decide not to go down that route once you've talked about it. But it may be worth a chat.
Thank you, Neil. So next question, is nocturia common post-nephrectomy? I have been told by several people that this can happen, but it did resolve itself after several months, please.
It's not a standard physiological response to having kidney surgery. There is a change, of course, and a lot of it depends on your background renal function. So there is a change. You lose a functioning organ if you're having a nephrectomy, and your other kidney quite remarkably does step up to the plate. You're born with a certain, well, by the time you're 18, you have a certain number of functioning units of the kidney, nephrons, and you don't get more. So there is no regeneration, or there's no growth of more. But what the kidney does do is, through various local hormones, increase its blood supply essentially, and the functionality of each one of these little units. So you'll see, if you were doing blood tests to monitor kidney function, you see it drop off and then climb again over the first year. Really, it depends on person to person, and during that phase you will see perhaps a change in the way in which the kidney manages fluid in the body. So yes, you may see changes. I haven't heard of anybody having nocturia like that which then resolve, but that would be the explanation behind it, as there's been a change in the local hormones which are influencing how your body manages fluid. And what happens is at night, because particularly if you're a certain age, your heart pumps and the movement of fluid is more efficient when you're lying down rather than standing up, and it takes the opportunity to offload fluid, so you end up making more urine at night. And then as your kidney function starts to improve and take up the slack to some degree, then you may see it flip back to a more standard pattern of secretion.
And just one more thing, a lot of patients after they've had a kidney out do drink more than they've ever drunk before, and so they do tend to then get up in the night to pee more. And so, you say to the patient, are you drinking more than you normally would? And they go, actually, yes, I am, because I've only got one kidney. So they're consciously aware that they need to drink more. So sometimes that's another reason why patients suddenly say that they're waking up a bit more often in the night.
Thank you, Jo. And this brings me on to another question, actually. It's something we get asked again and again and again. Obviously, for those that only have one kidney remaining, and how obviously it's so important they preserve that kidney function. Is there anything particular that's the optimum things to do, like have less sodium, for example, to like do the best by that one kidney they've got remaining?
I think there are so many factors that can influence kidney function, but I think you don't want to get yourself lost in the minutiae of picking out little things and altering great big impact on the quality of life, because actually fundamentally there are 3 rules that apply in terms of preserving kidney function, and that's true whether you've got 2 kidneys or 1 kidney. And of course your backup's gone if you've got 1 kidney, so it becomes more important. But it is about a healthy lifestyle. I know it's a banal statement, but actually the well publicized balanced diet is the best diet to be having, which is good for your kidneys. Yes, you probably don't want to be eating 14 packets of crisps a day, but you probably shouldn't be doing that anyway. And that just becomes more important. So, but if you focus on not about what you shouldn't particularly be eating, but about your diet generally, the same then remains true in terms of other aspects of lifestyle. So regular exercise, and we should be doing that anyway, but it becomes more important when you only got 1 kidney, or you've got some loss of kidney function. And finally, how that all feeds into the 2 big killers of kidney function, which are basically high blood pressure and diabetes. There are other things, but that covers the vast majority of things that we can really influence. So guess what? What does that come back to? That comes back to a healthy diet. It comes back to regular exercise. It comes back to not getting obese. It comes back to keeping an eye on your blood pressure and making sure that appropriate treatment's in place if you have high blood pressure. And both of those mechanisms will reduce your issues with high blood pressure and reduce your risk of getting particularly type 2 diabetes. And if you're doing those things, then in reality, you're doing all the right things, and you don't need to get bogged down in specific diets or specific lifestyle changes, because actually the evidence is that those things will put you in the best place possible to protect what kidney function you've got. And remember, most people, not all, when they lose a kidney for kidney cancer, the other kidney is a good kidney. And you are born with 2 for a reason, and there are plenty of people wandering around out there who have 1 kidney and never know it, or have lost the function earlier on for whatever reason. So having 1 kidney, yes, you've lost your backup, but if you maintain that concept of a healthy, balanced diet with exercise, not getting obese, looking after your blood pressure, then you're doing all the right things fundamentally.
Perfect. Thank you, Neil. It's a really good answer. It covers lots of questions all in one. And I'm guessing also with alcohol, that would just be in moderation, would you suggest as well? Because we get asked that quite a lot as well.
Only the best quality is the answer.
This is a statement rather than the question, and it's to you both. Hi, my name is Anthony Duthell. I have been fighting kidney cancer for 10 years. I've had a full and partial nephrectomy. I've had both procedures with Neil and his team. I just wanted to say that they were very, very good, and I was totally at ease. And I just wanted to say a huge thank you. So thank you, guys and girls. So thank you for everything you do.
Thank you.
Thank you. And Sally, I think you put your hand up to ask a question.
Hi
Sally. Hi Sally.
Hi everyone. Really, it's a bit of a two-pronged question. One for Joe. What sort of input do you have with patients post-nephrectomy when they're classed as a low risk of recurrence?
Okay, so if somebody's histology comes back showing that they've got a low risk kidney cancer, they go on a pattern of surveillance. There's 3 categories: low, medium and high. So patients will get scanned according to the protocol. So presently it's a 6-month scan, followed by a one after a year, and then yearly for 3 years, then up to 2 years to 5 years, and then another 2 years to 9. We are just about to change our protocol, actually, and I think different trusts, use different guidelines. So patients, I will speak to them with their results in a telephone clinic. I will be there to help, if they've lost any blood forms that they need before their scans. They've got my contact details. So I will pretty much speak or keep in contact with patients, for up to 5 to 9 years, like I said at the very beginning. They have my number, so they don't have to wait for their next scan. If they've got any problems, queries or concerns, they can give me a call. So, patients have quite a lot of access to myself. Saying that, at the Frimley Renal Cancer Centre, we are very privileged because there is one of me, and that is my main role. A lot of trusts have specialist nurses that have dual roles that look after people with different other cancers. So I would say that patients at Frimley are, lucky to have that access to me sort of 24/7, really.
And if something was flagged up on another scan, would then you refer them to back to their surgeon, or would it be another consultant? Yeah,
so we are classed as a team. We're a multidisciplinary team. So if any abnormality is picked up on any scan, then it's my job to make sure that patient is discussed back to our specialist MDT meeting, where the consultants sit along with oncologists, radiologists, specialist nurses, where people's cases and images are reviewed, and a management plan that's most appropriate to the finding is made. Sometimes that would just involve, myself referring patients onwards. If they need to come back to clinic, I'll facilitate that clinic visit. But all patients are discussed through an MDT if there's any abnormalities on that scan.
Okay, thank you very much.
That's all right. Another Welsh person.
Yes, from Swansea.
From Swansea. There we go. So I trained in Swansea many years ago.
Oh, the best people always come here, you see.
There you see. Neil, are you listening to that?
My dad went to university there. You know that already.
Of course. Of course.
Thank you, guys.
Thank you, Sally. The next question: I had a radical nephrectomy in September and have some numbness on my abdomen. Is this part of the healing process? And also, how do I know when I'm fully healed internally, as I'm anxious about overdoing it?
I think the at this stage, was it September, wasn't it?
September,
so we're 4 months. Go for it, basically. It will be as healed as it's going to be in there, and in fact the irony is, as Joe was speaking at the beginning, actually the earlier you get doing things, the more supple you keep the muscles, and the less stiffness, and the quicker you get back to doing things, really. So certainly I would, famous last words, but I think it's very reasonable to, that you should feel confident to do all the things that you want to do. The numbness and tingling, as I say, around the wound is the nerves healing. So you cut skin, you cut nerves, and they will heal up. And mostly, but not in everybody. Sometimes, if you're unlucky, you can be left with an area of numbness and tingling. But mostly, with time, eventually, it does heal. It's incredible, really. But it can take years if you're very unlucky. But most people within a year, those type of symptoms will disappear.
Thank you, Neil. Sorry, questions. Can anything be done to support the muscles on recovery, e.g. physio or Pilates, 3 months after an open partial nephrectomy, or does that risk getting a hernia, please?
I think keeping your core muscles strong is the best you can do. You know, as I say, this is about muscle injury and healing, and the tone in the muscles in some people just never recovers, and you end up with this bulging. But giving through core exercise, so Pilates and yoga and that kind of stuff, you're giving the stability to allow the best tone that you can have. So you're very unlikely to do any harm. If it's a true hernia, yes, if you strain and push, it will get bigger with time. But then mostly these aren't true hernias. It's actually muscle weakness, if you like, or differences in tone in the abdominal wall. So I think, yes, it's the right thing to do to try and improve that tone generally, but be realistic in terms of what impact it may have upon this bulging, because I say, unfortunately, it can be with you and stay with you.
Thank you. Can the presence of accessory arteries and veins in my kidney have increased the chances of my developing kidney cancer, or have added to my early onset of hypertension, which I know is a risk of kidney cancer?
So two things, taking the second one first, there is an association with particularly large tumors when they can be metabolically active, and there's lots of hormones that are made by the kidney, and you can have upregulation or downregulation of those in some tumors, and there can be all sorts of symptoms that can be associated with that, which high blood pressure is one of them. But it's not necessarily linked to the presence of a kidney tumor. Again, there's smaller ones, it will not be linked to that. These are larger tumors where they are metabolically active in their own right because of the cells they've arise from. In terms of the accessory vessels, no. I mean, there is, if you draw a picture of a kidney, you have one artery and one vein, and they sort of divide at certain places to feed and drain the kidney, but actually there is massive variation. And so having so-called accessory vessels is not actually that uncommon, and to my knowledge doesn't increase the risk of in fact, either high blood pressure nor indeed kidney tumors. It just makes the surgery a bit more complicated.
Bless you. Thank you, Neil. Thank you. Had a radical nephrectomy 16 months ago, stage 3, being scanned every 6 months. Is there a point at which I can be fairly sure of no spread?
Protocols, Joe was describing how long the protocols run for, and it's for a reason. So yes, as every 6-month scan passes by, the chances of recurrent disease, be it locally, in the bed of resection, or metastatic disease, drops, that's for sure. But if it, the reason that the line in the sand is quite long in terms of the protocol of follow-up is because unfortunately they can pop up, really quite many years in the future. So it's important to keep with the protocol, have the surveillance scans, particularly in this era. The world's changed a lot in terms of the management of metastatic disease, and it's a completely different world to what it was when I was a junior doctor, when there was nothing basically, or some treatments that you probably would never want. And now there's a plethora of different treatments available. And indeed, if you're picking up lesions early, then often you'll go after them surgically or some form of intervention to treat those recurrences alone, if it's, say, one solitary one. So it is worth keeping an eye on it. And sadly, yes, they can come along really many years after surgery. But as I say, with every 6 months, that figure drops down. But the protocols are there and are long for a reason, I'm afraid to say.
Yeah, and I say to the patients exactly the same. We are scanning you for a reason, and we're, almost looking, scrutinising those scans when they're done to make sure that if anything is picked up, then we can act on it straight away. And many patients, when we spread those time periods out and they get longer, that's when they start getting anxious. And if we push somebody out to a 2-year scan, you know, a lot of my patients don't like that. They get anxious, and that's quite normal. So, you know, the scans will become less frequent, I would imagine. But like Mr. Barber said, they will go on for a while.
Thank you. Something else that I know a few patients have asked and emailed in about is, should patients, when they're having surgery, get offered to go on the clinical trial, for example, the Rampart trial, and how often is that offered? And is it certain patients that get offered the trials and certain patients that do not?
So the sort of NHS directive to which we all sign up to means that all cancer patients should be discussed with an MDT. Most regions run a specialist MDT for either a selection of patients or all patients. We do, in fact, for kidney cancer within the region, which, you know, is a burden of work, but that's the way we play it. And through that process, this is true for all cancers. If there are trials available, they should be considered for it, and if appropriate, offered inclusion in that trial. So, but not all trials will necessarily be run within that cancer region. So, you know, if Rampart, for instance, is being offered only in a certain number of centres around the UK, if you're not part of a region that's offering that, then, you know, you will not necessarily be offered inclusion in that trial, because it's not a standard of care. It is a trial after all. So I think the paradigm is, if there are trials available, then they should be, and we are monitored on that, about the, you know, how many of our patients we are offering trial inclusion into.
Brilliant, thank you, Neil. And another question: what should the GFR value be after a radical nephrectomy?
So there isn't an answer to that, because there isn't what it should be. Essentially, and this often confuses GPs, particularly if you're a bit older and your renal function is okay, but not a 20-year-old's. Thereafter, your EGFR, which E being estimated, remember, it's not an exact science, will drop, and it will drop to below a figure of 60, and that GPs go, oh my God, that's abnormal, you've got chronic kidney disease. But actually, you would, you know, in many people, you would expect it to. Of course, you've lost half of your functioning organs. And as I mentioned earlier on, you will, in fact, in the first year, see a decline and then a rise up to a certain level, but it may not cross that so-called normal boundary. But that normal boundary is measured for a population with 2 kidneys. Yeah, so you are not that person anymore. You are not part of that normal group. What you really want to see is that your EGFR is obviously good enough to keep you off dialysis. That's really quite important, but also that it's stable. So most protocols will then include, only with the scanning, but also blood tests to keep an eye on your EGFR. So it's not so much about necessarily its value after nephrectomy, it's about its stability, and that there isn't inherent kidney disease in your only kidney, which is leading to a fall over time, that you would want to get on early. Talking about all things, about blood pressure and diabetes and all that kind of stuff. So it's not about the value, it becomes about stability.
Perfect, thank you, Neil. Another question that we get quite a lot is, can you explain what a non-steroid drug is, and why, or should we avoid them if we've had nephrectomies?
It's interesting. It's quite a contentious point, actually, because there's quite a lot of difference in practice, not only in the country but around the world. And we had a fellow come from Switzerland, and they routinely give non-steroidal anti-inflammatories after nephrectomy, and thought we were completely bloody bonkers that we didn't, because they're such good painkillers. It is true that non-steroidal anti-inflammatories, this includes Nurofen, ibuprofen, diclofenac, that's Voltarol, naproxen. I'm going to run out of them now, but a whole bunch of them, and that they are potentially nephrotoxic, i.e. they can kill or have an impact upon these functioning units, the nephrons. And so you certainly need to be thoughtful about whether you take non-steroidals. If your kidney function is good, if you have a partial nephrectomy, you have a good normal kidney function, then you can take non-steroidals much as anybody else can. If your kidney function is terrible, maybe because you have pre-existing kidney function issues and you've lost a kidney, so you're running with a low EGFR, then, you know, obviously every unit is a little bit more precious, and you need to be a bit more thoughtful about taking something which may be toxic to the nephrons, because you are more vulnerable. So a lot of that is individual. And I don't think for anybody who's had kidney surgery, taking non-steroidals is off the table completely, although it's easily read like that and understood like that. But a lot depends on your residual kidney function and other comorbidities. So have you got high blood pressure? Have you got diabetes? Are you at risk of losing function over time because of other things?
Perfect. Great answer. Thank you, Neil. I learned as well. Thank you so much. Thank you. I have a 20 centimetre kidney tumour with no visible secondaries going to be removed in 2 weeks by open, I think it should be partial nephrectomy. Is it possible to say how long the tumour has been there and how long the tumour has taken to get to this size?
No. I mean, I think in 20 centimetre tumour, you know, these are the ones we're talking about being open surgeries, be a radical nephrectomy, I would have thought. And I'm very pleased to hear there's no signs of any spread, because obviously by definition it's been there some time to grow up. It's difficult to know at an individual level. We know that particularly in older patients where we do more and more surveillance of small tumours, that the average rate of growth is about 3 millimeters per year, 2 to 3 millimeters per year. So they're generally quite slow growing. But as everybody, people have mentioned today, the vast majority of patients that come to us, these are picked up by chance rather than symptoms. But it's only really once you get to that kind of size that you may have either a lump you can feel, a greater chance that you may even have discomfort from it, or blood in the urine. So it's that size of tumour that you may start to get symptoms. But I hope the operation goes well. It's a big old lump. If I had to guess, I would say it's been there for easily many, many months, but probably in fact a good number of years. And I do mean a good number of years.
Perfect. And apologies, I meant radical nephrectomy. The wrong thing came out of my mouth. I realised what I was saying. Like, oh no.
Neil and I, did you see it? Both of us were a bit like.
I apologise. I've got this tiny screen trying to read all the messages, and I apologise. That was completely my fault. And Colin, not a question, just a positive story. And thanks to the Royal Free in London, 11 weeks ago, had a robotic removal of the entire left kidney, but no adrenal gland and TCC and bladder cuff. After a few days home, was walking around the block. After 9 weeks, was jogging again and off-road cycling, feeling great. Only one thing I don't do is touch my toes, taking that kind of stretch very carefully. Scars, 4 2 centimeters and 1 8 centimeter, fainting considerably. Would prefer to have them as battle scars to show off. So yeah,
that's brilliant, and that just goes to show how quickly people recover. I mean, I speak to people, I give them a call usually 2 days after they've been discharged, and at that point they usually are struggling with pain, maybe constipation, bit of nausea, and I say to them, in 3 weeks time when I speak to you again, you're going to feel like a different person. And I'm sure they don't believe me. And when I speak to them with results, they are literally, most of them are off all their painkillers. Some of them are back to work. They're already out and about. So, it is amazing how quickly your body can recover. And then usually by, the 6 month mark, when I speak to them next, they've almost forgotten that they have ever had an operation. So it just goes to show, stick with it. Those that are just out of surgery and who are feeling a bit poorly, you will get better. You will definitely get better, I promise you. It's sort of, just one day at a time.
Thank you, Jo. Another question, what would you say is a low EGFR?
So, I mean, a low, you start to move towards the need for dialysis when you get down to about 10. And there are many people, particularly older people with pre-existing disease, that that you may lose your kidney and be toddling along about 20 and fine, no symptoms at all. But once you start to drift down to that kind of 10, 15, 10 value, then you may well start to notice it just in terms of your general well-being, and you're drifting towards some kind of renal replacement therapy. But above that, as I say, it's about, these are definitions, aren't they? So below 60 is considered chronic kidney disease stage 3. That's what your GP will fling at you. But in reality, after surgery, if you're running at a constant of 40, 30, 50 something, it's fine, as long as it's stable. And it's not really till you'll get down to, let's say, around about a 10 value that people will start getting a bit sniffy about whether you need some kind of help on that front.
Perfect, thank you. Another question, if this is all right, how much water should I drink if I've had a partial nephrectomy every day? Is it
1.5 to 2 litres, the same as any other person, which, you know, I'm guilty of not doing that, but it's the same. It's, as Mr. Barber said earlier, it's about, you know, the normal healthy lifestyle that, you know, everyone should be following. So you don't need to drink any extra, just, you know, the recommended guidance for everyone.
Perfect, thank you. If you're all right for a couple more questions, another one is, after I've had my surgery, how long should I have to wait for my pathology results?
I mean, I can answer that one, but if you want to add anything, we usually say that results can take anything up to 2 to 3 weeks. So our patients are booked into my clinic usually 3 weeks after their surgery. It's not uncommon, though, however, some results to take longer. Some have to be sent away for second opinions, for more what we call immunostain testing. And so sometimes patients can sadly wait, you know, 6 to 7 weeks for results. Not often, most patients get theirs back within 2 to 3 weeks. But some cases do need to be sent away for second opinion. But I would say the average is probably 2 to 3 weeks.
Perfect.
I'm afraid that, yeah, the influence in all this is a local, you know, staffing, really. So, you know, that's what we have, and we run out, and that's pretty predictable that Jo will know the results will be there when she's going to speak to them. How it is in other trusts is, you know, pathology labs and consultant pathologists are one of the areas of hospital medicine where there are staff shortages, and that's been chronically the case for a long time. So, you know, the burden falls fairly and squarely upon who's there, and that can really have a big influence. I know there are a number of hospitals where they just don't have pathologists, and so the backlog can be really quite significant. There are other ones where they've got, you know, they're overrunning with pathologists, and they'll turn over the specimens much quicker. So, but it is like all aspects of healthcare, you know, what there is, as has been in the news again today, it's the staff shortages, and, you know, we're not going to magic up more people overnight who can make this all turn around quicker. But what I do say to patients is, you know, when you're having kidney surgery and that surgery is aimed to cure you, which is what we're trying to do, you know, it's not necessarily, sadly, what we achieve, but it's what you're trying to do, is that once it's done, it's done. You know, if the pathology took 6 months, it doesn't really change anything in terms of where you're at. Don't worry about that. It's your focus should be about recovering from the operation, getting back to normal, and getting on with your life, and the rest of it will take care of itself. Remember, at the moment, at least, there is no role for any adjuvant treatment, that is chemotherapy, as you might understand it, or some kind of biologic therapy after surgery. So you're not waiting for something else. You've had the treatment, and then it's just a matter of surveillance. So people get bogged down, and, you know, they want to get the pathology, and I get that, because people want to know, you know, that's just human nature. But actually, it changes nothing. The focus should be about your recovery from the operation. What is a risk event? You know, it's a lifetime risk event, and you need to take that time to get over the surgery and recover, and the pathology bit will look after itself.
Perfect, thank you, Neil. Another question is to do with genetics, actually. I have 2 children, and wondered if there's evidence of hereditary disease like there is in other cancers, with kidney cancer, and obviously how could they get genetic testing?
So there are genetic links. All cancers, to a greater or lesser degree, have a potential for genetic link, and there is with kidney cancer, both the clear cell type, which is the commonest type of kidney tumors, and also some of the more rarer types. So papillary is one of the rarer subtypes, and that too has some inherited conditions. They are quite rare, actually, and really, we only raise the flag about whether that may be the role in people presenting at a young age themselves. So for as a rule of thumb, let's say in your 40s, and if somebody comes on with the kidney cancer, then we do, you know, not straight away focus on the task in hand, which is dealing with that. But down the line, once you've got the pathology, depending on the cell type, then we do recommend that there is genetic testing for that. And there are various units around the country. So for us, being in the southeast, that tends to go through the department at the Royal Marsden.
Perfect. Thank you, Neil. And one more question. Is there a time limit for the acceptance on a trial post-surgery?
I mean, it utterly depends on the trial, to be honest. So if it's a surgical trial, then you need to be informed and consented regarding that before the surgery. If it's a trial involving treatment for, say, metastatic disease or recurrent disease, then obviously at that point in time you can then be approached in terms of inclusion into a trial. So it really, it depends completely. We're part of a global trial at the moment, looking at various urine and blood tests to see if it can pick up tumor recurrence before the CT scans, and that recruitment has to start before the operation. In fact, not all people will be formally recruited because it's the pathology which will determine whether they're eligible or not. So, but we still have to recruit them before the surgery, even though a proportion will not, happily in many ways, because it means their kidney cancer is not bad enough, but before they are recruited into that study.
Perfect. Thank you so much, guys. Is there any other questions for Joe and Neil? You've both been amazing tonight. Thank you so much.